Welcome to the Explainer. Today we're jumping straight into a rapid-fire clinical gauntlet. We're going to tear through high-stakes trauma, burn management, and toxicology protocols. No fluff, just the critical facts. Let's hit the first scenario. Picture this. A patient arrives in a severely confusional state right after being trapped in a burning car. By which method is carbon monoxide poisoning detected most reliably? Is it A, pulse oximetry, B, Doppler ultrasound, C, arterial blood gas analysis, D, clinical assessment, or E, venous blood gas analysis?
If you guessed C, you nailed it. Arterial blood gas analysis with direct co-oximetry is the gold standard here. The absolute crucial point you have to remember is that standard pulse oximetry is completely unreliable in these cases. Why? Because a standard pulse ox literally cannot tell the difference between carboxyhemoglobin and normal healthy oxygen. If you rely on it, you're going to get a falsely reassuring, totally normal oxygen saturation reading, all while your patient is suffocating at a cellular level. You absolutely must use an ABG.
Building right off that invisible threat, we need to know our exact thresholds for action. At what percentage of carboxyhemoglobin in the blood will you administer 100% oxygen for 24 hours? Is it 2%, 4%, 8%, 10%, or none of the above?
The magic number here is 10%, option D. Hitting a carboxyhemoglobin level of 10% indicates clinically significant carbon monoxide poisoning, and this mandates immediate 100% high-flow, normal baric oxygen. This actually illustrates a brilliant physiological hack. When you're just breathing normal room air, the half-life of carbon monoxide in your blood is about 4 to 5 agonizing hours. But when you flood the system with 100% oxygen, you violently displace that carbon monoxide and drop its half-life down to just 60 to 90 minutes. It's a real game changer.
All right, shifting gears from toxins to internal conduction, let's talk electrical trauma. For high-voltage electrocution, which aspect is the most important to manage? Are we looking at altered mental status, wound site infection, bone fractures, myocardial damage, or nerve injuries? Now hold that thought and compare it to a domestic low-voltage shock. Let's say a 33-year-old accidentally gets a 220-volt shock from a household appliance and physically cannot let go of the wire. What is the most likely immediate complication here? This perfectly illustrates a critical divide in electrical trauma. For high voltage, meaning anything over a massive 1,000 volts, the primary threat is D, myocardial damage. That kind of current literally cooks deep muscle tissue and causes severe structural damage right to the heart muscle. But for low voltage alternating current, like that household wire, the electricity traps the victim in severe muscle tetany. They literally can't let go. That continuous loop disrupts the heart's conduction system, making option D, arrhythmias and sudden cardiac arrest, the primary immediate threat.
Let's push that high voltage scenario a bit further. Say our patient is a 44-year-old male with a high-voltage electric burn, and you notice he has decreased, dark, tea-colored urine. What's the best immediate management step from these options? You've got to go with B. That dark urine is a giant red flag for severe rhabdomyolysis. It means massive amounts of intracellular myoglobin are spilling out of that destroyed deep tissue right into the bloodstream. You must aggressively double the standard thermal burn fluid target. Usually, you aim for 0.5 to 1 ml per kilo per hour, but here you need to crank it up to 2.0 to literally flush that toxic myoglobin out of the renal tubules before it triggers catastrophic acute kidney injury. Okay, new scenario. When a patient has a circumferential, full-thickness burn affecting both upper limbs and an escherotomy is planned to relieve the pressure, which anesthesia technique is preferable? Local, regional, general, spinal, or no anesthesia needed? And while you're thinking about the pain management, consider the surgical approach. Where exactly do we place the escherotomy blade to avoid making the upper limb injury even worse?
The fascinating and frankly wild truth here is E. Absolutely no anesthesia is needed. Because it's a full-thickness burn, the entire dermal architecture is destroyed, and that includes the specialized nerve endings and nociceptors. The tissue is completely insensate. You won't feel a thing. And for the approach, the answer is A. You must cut mid-axially, right along those mid-lateral and mid-medial planes to successfully dodge the primary nerves and blood vessels while releasing that deadly tourniquet effect.
Moving on to assessing external surface area, because getting this calculation right is literally make or break for a patient's survival. Which of the following is incorrect regarding Wallace's rule of nines?
Did you spot the trap? It's option B. Each entire lower limb in an adult is actually 18% of the total body surface area, not 9. It's 9% for the front and 9% for the back. Memorizing this adult map is absolutely non-negotiable for rapid, accurate assessment in the trauma bay.
But what happens when our patient is a 5-year-old child? They have a completely different head-to-body ratio. We have a 5-year-old with burns on the face, anterior neck, chest, abdomen, and the front of both lower limbs, but the feet are spared. What is the total body surface area according to the London Browder chart?
Using the pediatric London Browder chart gives us way superior precision here. The answer is E, 34%. Here's how the math breaks down. The face is 6%, the anterior neck is 1%, and the anterior trunk, so the chest and abdomen combined, is 13%. For a 5-year-old, the front of the lower limbs, excluding those spared feet, gives us 14%. Add up the whole shebang, and we land exactly at 34%. Making this pediatric adjustment is absolutely crucial so you don't dangerously over- or under-resuscitate a kid.
So, once we have our percentage, we have to triage. Who actually requires specialized unit admission? Which of these options is a strict criterion for admission to a specialized burn care unit?
It's A, an adult patient hitting 15% burn total body surface area. Basically, any adult exceeding 15% or a child over 10% triggers immediate admission criteria. Why is that the cutoff? Because at these specific thresholds, the intravascular to extravascular fluid shifts are so incredibly massive that severe hypovolemic shock or burn shock is practically guaranteed without specialized, highly intensive fluid management.
Speaking of massive fluid shifts, let's do some math on the fly. A 34-year-old male has 22% TBSA burns and weighs 70 kilograms. What exact volume of colloids should be given in the very first 4 hours? If you calculated E, 750 milliliters, you are spot on. Let's walk through the Muir and Barkley formula, which systematically addresses those massive capillary plasma shifts. You take 0.5, multiply it by the burn percentage of 22, and then multiply that by the patient's weight of 70 kilos. That equals 770 milliliters, which practically approximates to 750 milliliters of plasma for that ultra-critical first 4-hour block. Alternatively, what if we're running a pure crystalloid rate? We've got a 50-year-old, 70-kilogram male with burns to both upper limbs and the entire front of his chest and abdomen. What amount of fluid should be started immediately?
The answer here is B, 600 milliliters an hour. Let's break down the famous Parkland formula. First, calculate the total surface area. 18% for the upper limbs plus 18% for the anterior trunk gives us 36%. Next, plug it into the formula. 4 milliliters times 70 kilograms times 36% gives a massive 24-hour total of 10,080 milliliters. You slice that number exactly in half for the first 8 hours, giving you 5,040 milliliters. Divide that by 8 hours and you lock in an infusion rate of 630, which neatly approximates down to 600 milliliters an hour.
The ultimate exam pearl to take away from all this math? You absolutely must know exactly when to utilize a crystalloid like Ringer's lactate under the Parkland formula to minimize hyperchloremic acidosis, versus when you need to use an albumin or plasma-based algorithm like Muir and Barkley to aggressively counter oncotic fluid shifts. Don't get them mixed up.
So here's the final question to leave you with today. When seconds count in the trauma bay and chaos is erupting all around you, do you have these exact formulas, thresholds, and clinical traps memorized to save a life? Review these numbers until they are absolute second nature. Keep your head in the game, and we'll catch you on the next explainer.